focus, right? Yep. Okay, now zoom in all the way. So now when this time, do you see when we zoom in and zoom out, the microscope stay in focus. Mm-hmm. At the beginning, when we zoom in the microscope and then it lose focus, right? Mm-hmm. So which one do you prefer? We prefer the microscope, we zoom in and zoom out, stay in focus, right? We don't want a microscope when we zoom in and then lose focus. Mm-hmm. And then we have to reset the microscope. So what caused the difference? Why at the beginning we zoom in and then lose focus, and now it stay in focus?
Because it wasn't at the right height? The microscope?
Yeah, kind of that. So that's what I wanted to. Now I want to talk about the depth. Here, before we will talk about the depth, I want you to think about space at 4 times. This space is like 6 centimeter wide and 2 centimeter high. That's the space we can do microsurgery. Pretty comfortable, big space. When I go to 24 times, that space become this big and only 2 millimeter high. That's the space we can do microsurgery. Because out of that we cannot see clear. So it becomes really hard. So in one of the principles in microsurgery is go to the lowest power, lowest magnification, we can see the vessel clear. And then that way we have bigger space to do microsurgery and feel more comfortable.
More space.
Instead of
three-dimensional space to work on.
Yeah. Instead of going to a higher magnification to see the things bigger. When the space is minimum, it's really hard to control. It requires higher control of your finger, and you cannot move too far away. And when you cannot see outside, you're getting fatigue and get easier. So this is one of the I want to tell you, explain by what you see. Now become 24 is really tiny, right? 2 millimeter high. When we raise a little bit, and then out of focus. Even like the clamp size already higher than 2 millimeter, so it's really hard. So even the microscope in the OR, they said like the Mataga, they can go to 30, go to 50. No, I try, I test myself. Even I do the super microsurgery, like theoretically like super microsurgery, 0.3, 0.5 millimeter anesmosis. Actually, I don't need to go to 20. Like 15, 16, I already can do that super microsurgery, the maximum. Now they report. Some of my teachers and my Japanese friends said they can do 0.0, 0.2. This is, they said they can do 0.2 this vessel and put 6 stitches there. So I try like 0.3. I put 5 stitch there. Only I really see I see how high magnification is required to do that. And then actually it's not even go to 20. I just go to 16, and then I can do this anastomosis. So it's not true. We underestimate our skill. We thought we need to 30, 50, but actually no, it doesn't. It's not true.
Yeah, more power is not more.
Yeah, a lot of people like in even we thought the vessel is way smaller than actually it is. Now we
Right.
think, oh, the finger maybe just 1 millimeter. No, the finger is still beyond 1 millimeter vessel, pretty big.
Yeah.
Pretty big. Now go to the depth. Remember at the beginning when we can see the ruler clear, that means the depth at the 4 times. This is 4 times magnification. The depth is like 2 centimeters. Then we can see clear. This ruler may be in here, maybe in here, maybe in here. And then maybe zoom out to 24 times. The depth become 2 millimeter. So if the ruler not right in between here,
Can't see it there.
it fell out of focus. That's what happened at the beginning.
Right.
Right? It out of focus when we zoom in all the way to 24. But then we set up the microscope, we focus the microscope, and then we can see clear. The ruler is in here. And then we zoom out the microscope, the depth become bigger.
Mm-hmm.
So the bigger depth will definitely including small depth inside. So that's what happened. When we focus in the higher power, we zoom out.
Everything
The
else
microscope stay in focus. We zoom in to higher power. It didn't change.
But the depth.
Yeah, yeah. So that's the real practice how we use the depth in the septic. It's more important in setting up the microscope. So there's a terminology is parfocal. Yeah, I know the microscope will happen like that way, but I don't know that's the terminology until I talk to the Zeiss representative. And they say, oh, that's parfocal. The way to get the parfocal, that's the best stature of the microscope, right? Best stature.
So you focus on your deepest,
Yeah,
your higher power,
yeah,
and then everything else stays in focus when you focus out. Or
Yeah.
you zoom out.
yeah. So it mostly happen in line of like finger replantation. We may use 6 to repair the nerve,
Right.
and then maybe we'll go to 8 to repair the artery, and then we go to the maybe 10, go walk on the vein. So if we set it up in like 16 or 20, we may not have to, like the Mataka, they can go to 30. We may not have to go to 30 to set it up because we suppose we don't need to go that high.
Right.
But when we set up in the focal setup, it's very convenient. We just change and do zoom in and zoom out to do microsurgery.
Right.
Yeah. Okay. Yeah, that's mostly about the microscope. Now I think you know when you go to the OR, you sit there, you know, first
How
part
to,
here and there, and then you understand that. And even there's a small problem, you cannot see clear. You won't panic. Okay, just turn
And
it.
troubleshoot.
Yeah, just turn this one. The mega glasses for you.
Right.
Yeah. And then okay, that's the microscope, and then the instrument. So for the instrument, now we see there's a lot of instrument there, but actually there's only 4 instruments. So this Caesar. Caesar, forceps, dilator, forceps, Caesar, scissor. This is all needle holder. You won't see so many, all kinds of needle holder at the same time. Yeah, now this is the scissor. So, yeah, tell me what do you see different? What different do you see?
And this?
So there are 4 instruments: needle holder, scissor, forceps, dilator. That's enough for microsurgery. You see there's a lot of things, but actually 4 instruments.
Okay.
Yeah, tell me what different do you see?
Tip fineness and how fine
Yeah,
they are.
yeah, that's the most important part. All the money is paid for the tip.
Huh?
All the money is paid for the tip. If the tip broke, and then we lose that.
That's it.
Yeah. Yeah, and then the color, right?
The color
So
is
this-
the material, right?
Yeah, yeah. So this is the titanium. This is the stainless steel.
And
Yeah.
this?
Yeah, this rainbow one is the now rainbow one is the standard set for the super microsurgery. That's the most expensive one.
But what is it made of? Titanium too?
Yeah, titanium.
Okay.
Yeah, and then you can see the tip. This one is way stronger, right?
Right.
Power. So you can hold in a bigger needle like 8O, 9O, pretty good. This one is really thin, so it's not strong enough to hold in a big needle to pierce a big vessel. So we only use this one to hold in the 9O, and then working on a really thin vessel like a lymphatic vessel. Usually it's sub-millimeter. 11O we only use on smaller than 1 millimeter vessel. So we don't need to holding it very hard. This one you cannot hold the needle very well. If you use on a 9O, it's always very easy to twist. That's the problem. And you can see this one is the scissor and needle holder combined. That's one
That's
very
dangerous.
special thing. Yeah, I bought this one for kidney transplant in Iraq. Because the protocol require the warm ischemic time is less than 30 minutes. We need to finish the way after we take the kidney from the ice. So it's really hard. In the Roden facility, the microscope only allow 1 people. I don't have assistant. So
You can't be changing your instrument all the time.
yeah, so after I put a stitch and then I put it down and then pick up a scissor and then cut the suture and then put down the scissor and then pick up the needle holder again.
It's too much.
When you have only 1 person, you feel, wow, that's too much
Yeah.
step for 1 stitch. Then I know there's 1 instrument like that. And I bought this one, so I finish the knot and then I cut it and I keep going, making me save like 5 minutes and I can finish kidney transplant like 28 minutes. Before that, it's kind of always like 32, 34. It's hard. Although I already set it up very, very well, I just go right to doing the anastomosis. But you don't have a system kind of 50 minutes for 1 anastomosis is really fast already. It's pretty hard. So, but one of the problem is sometimes I cut the suture before I finish the running suture.
Dangerous.
Because when I try to pick up the needle, I don't know the scissor get caught inside the scissor, and then I pick up the needle and then suture already cut. Now you can take a look at this is a locking needle holder. You can see how it locks. Yeah, look into the microscope. Yeah, see that? There's a hook. When you reach the hook, it lock. When we push beyond the hook, it unlock. So the locking instrument, there's one good feature. It's like similar to we use this needle holder. We can catch the needle and put it there. We can load the needle on the needle holder and then lock it. But that's not convenient. The disadvantage is while we're doing anastomosis, once we push too hard, and then it lock, and then we have to unlock it. We have to unlock it. When we try to unlock it, it's a big drum. So I don't like the. Actually, I don't like the locking instrument
Yeah.
because it's not. You cannot use it freely.
Yeah.
I still like this. You can open and close by the spring.
Mm-hmm.
Yeah, and then you can compare the tip. This is a stronger tip, and also this is a flat handle and round handle. So why some of the like Dr. Paul he like the flat handle, and I like the round handle. So at the beginning I thought it's because of personal preference, but later I realized maybe it's because of different surgery we do. Like Dr. Paul they did a lot of DIEP. DIEP is a big piece of fat tissue, so their hand, their glove, it become greasy. So the round handle is not easy to control sometimes, and it always kind of slip. So the flat handle is more, they can holding it more steady. So that's good. And for me, I was a hand surgeon, so we mostly our hand is the bloody glove, so it doesn't matter. And the round handle is easy to turn, so I like that feature, so I can turn and change the direction of the instrument easier. Not only the needle holder, but also the forceps, so I can turn easy. So like this flat handle forceps, sometimes you cannot. It's not easy to turn. You have to turn your hand. So I like the round handle a little bit better. But I think when I'm doing DIEP, I may like the flat handle also, because it's more convenient. And the most important part, remember, is the tip. Like this is the standard set of the thoracic surgery. So when it goes to the standard set, the tip size is 0.3. Can measure it. See, it's very accurate. It's very close to 0.3, right? See that?
Mm-hmm.
Like this one is also 0.3.
Mm-hmm.
See that? You see, I'm not really. Like this one is almost like 0.4 to 0.5. So this is a bigger needle holder. Some of the needle holder even bigger, like in the cardiovascular surgery or in the transplant surgery or in the neurosurgery. The tip is kind of way bigger than like this one. This one you can really holding a file needle, you won't break. You won't damage the needle holder. So, and standard is 0.3. So even like the standard forceps is also 0.3 tip. And like this one going to super micro, it's, you can see here some information here is 0.1 millimeter of the needle holder. So you can see the needle. The concept is a little bit different. It's not this size small. It's kind of thin. See, it's so thin, like 0.1. Yeah. And here I will tell you how to read the information. So SNT is the company. This C is the curve, 14 centimeter long. So that's what we can read in here. And here we can read RC is the round handle, curved needle holder, 0.1 millimeter tip. And here is like the length is 15 centimeter long. Okay, that's the needle holder. This scissor we can see like this is the big size of scissor. So this is standard setup, plastic surgery reconstruction. When it going to finer, that's for hand surgery. When it going to even finer, that's for super microsurgery. So it goes to standard. You can see the blade is 2 centimeter long. This one is the 1.5 from the joint to the tip is about 1.5. When it's super fine, the scissor is going to be this one is a little bit smaller, but this one is about like 1.2 long. So it's still not very fine, not fine enough for super microsurgery. Still big. So here's some information I want to write here. This is curved scissor, curved scissor. So you can see it's the scissor. The first S is scissor. This is D is dissection. The C is curve, 15 centimeter long. So the curved scissor is the dissection scissor. That's easy to understand. Like a general scissor, that's the curved scissor. We use curved scissor for dissection. We don't use the straight scissor for dissection. Like this line. Mostly the scissor is curved for the dissection. And then this straight scissor. Straight scissor. Now here's scissor. First S is scissor. A is adventitious. Straight, 15 centimeter long. So why name it as an adventitious scissor? But actually we didn't use it for the adventitious too much. In the microsurgery, when we prepare the end of the vessel for anastomosis, we want to remove some of the adventitia. Like the adventitia, like this vessel. And then we would like to trim part of the adventitia. So the goal is you don't want this fluffy adventitia going to the lumen, because the adventitia is the tissue, external tissue. It's the very it's the very strong coagulation factor, factor 3. So once you get into the lumen, and then the platelet, and they recognize that's something. I see something from outside. They will thought that's a hole, that's a window, so they want to block it, and that's started coagulation cascade. That's not good. So we want to trim it off to prevent it going to the lumen. Usually we just need to trim it like 2-3 millimeters away from the edge. That's it. We don't need to trim all the way. And at the test book, the test book will look like that. You pull the adventitia away by a forceps, and then you use a scissor, straight scissor, and then cut line here. I mean, I think that's the reason why they name a straight scissor as an adventitious scissor. But actually, that's too good to be true. If we can pull the adventitia all the way like that, that means this vessel already damaged by crash or by, it's already avulsion happened. So most of the time, we still use the curved scissor to dissect, to trim the adventitia a little bit from different orientation. So we only use the straight scissor to prepare the cut. Just cut it straight or make a spatula cut to match the size of the recipient vessel. That's all the way, only the way we use straight scissor. So it's not adventitious scissor actually. But they may name it because of that from there. So that's a scissor. Right here, there's a little bit more information on this one. So Luis, tell me what?
Scissor, dissection curve 18 centimeter.
So this is RA is the round handle, A millimeter of the diameter. So the round handle, they make it A millimeter as a global standard. Like the ophthalmic surgery instrument, they may make it a little bit smaller, like 7 millimeter. But in the plastic hand micro, it's all 8 millimeter. Here, this is a little bit more information. So, Myiah.
Scissor dissection curved 15, round, 8 millimeter.
So this F and 12 is, remember 12 is the blade length is 12 millimeter. So it's a 5 blade scissor. So F is 5. 12 millimeter long of the blade. So some of the company, they label the information very in detail. Some of them they just can make a scissor. Didn't tell you too much about that. That's a scissor. Now I believe you go to the OR, you will understand a lot more when you. This is the forceps. So there's a curved forceps. Yeah, bring the curved forceps here. Yeah. So this is 4 forceps. You can see the different size of the tip, different length, and different color, and different shape of the handle. So this is the long forceps. And you know they all JF. See, like JF. Right? See that? JF. So JF is jeweler forceps. So we still name it as jeweler forceps because microsurgery at the beginning we don't have forceps. So we borrow forceps in the jeweler company, and then we still use their forceps. So this is like a jeweler forceps, angle, long forceps. These 3 is 0.3 tip. They make it really accurate, right? You can see this tip is also 0.3. See that? So this is the jeweler forceps 5. This 5 is the 5-inch long. So this one is the Super 5 forceps. Then is the 12 centimeter long and 0.05. So 0.05, that's super microsurgery. I think about if you walk on a 0.3 milliliter lymphatic vessel, if we still use this 0.3, it's hard to pick it up. So that's why this one is can make you a better surgeon. This instrument. You can see the tips. You can see the difference of the tip size. See that? Really sharp. So it's like this rainbow is 1/6 of the 0.3 forceps. So in this forceps, the instruction of using it, like sometimes we tap the instrument on the table and then adjust it. So like this forceps, never tap the on the table, because once you tap on the table, you lose that 0.05 tip. Yeah, and then there's one of thing, you can see it designed very well, only touch the tip. It's very accurate, so it pick up things very, very good. But think about if we want to pick up a suture, that will become really hard. We have to pick up right on the tip, so that's hard. So that's instrument is not good for the when we handle the suture, like tying knots. Like this long forceps is better. It can touch on the tip, one segment on the tip, so we can catch the suture better in this forceps. Yeah. Now this is the dilator. So the dilator, when we use the dilator, is mostly is kind of in anesmosis. We cut the vessel, we trim the vessel, and then we use saline to irrigation, and then a smooth muscle we tend to kind of close the vessel. That's expensive. So before we do the anesmosis, we put the dilator to make it go back to the normal size, or dilate it to a bigger size to match the difference, to reduce this discrepancy of the receptive vessel. You can see that the tip is smooth as a taper tip, so making it's kind of less risk of damage the vessel. So in the microsurgery, if not necessary, I never put anything inside the vessel. Even the irrigation, sometimes I see that they put the angiocatheter all the way into the vessel and raise it. I feel you need to pay attention to every detail to may cause the damage to the intima, because the intima is the best barrier of preventing the thrombosis. It's not a heparin, but it's the healthy vessel. If you damage the endothelium and it causes some damage of the intima, even we use a heparin, it still develop thrombosis. Like at the beginning, when I was doing anesmosis, I don't know if that's healthy or not. At the beginning, sometimes I see a tiny red spot there. I feel always maybe fine. I don't want to trim it too short. because that will cause some tension. I keep that small segment of vessel, but then it develop a thrombosis very quickly. After I finish the artery, I go to the vein, and then when I finish the vein, it already clogged, even a big size of vessel like the radial artery. So healthy vessel is very important. The healthy vessel should all in white color, no any red or blue color. So sometimes you don't want to cut that vessel, but actually you will spend a lot more time to fix it. Yeah, now you can see like the dilator design can touch one segment of the tip. See that? So that makes it better handling the suture. So that's why in the OR you may see during the anastomosis, the teacher will switch to use a dilator and a needle holder. That making it pick up the suture easier. Yeah. Okay, that's 4 instruments. And then there's other things like the coupler. Coupler, there's like this mirror the size of the vessel. This is the hockey stick. See the hockey stick, there's a hole there, so we can press the vessel wall on the nail and the pins of the coupler. This is the device for the coupler. Yeah. Now you see here there's an arrow. Here's an arrow. So put it there, and then this handle will go into here, and then there's a hook, and then you catch the handle. Yeah. Okay. Take it out. Yeah. So it's on. Yeah. And then we pull the vessel out here. Now you can go on the microscope. So there's pins. You pull the vessel out here and then put it on the pins. Like this is 1, 2, 3, 4, 5, 6. 6 pins. We do it the same of the microsurgery. We put one on here, and then we put one on here, and put 2 in between. Or we put one here, and here, make a one here, like make a triangle first, and then put one here, one here, one here. So it's the same way of doing stitching. Now you turn it and see what happens, how it closes there. Yeah, now you can see that these 2 arms, 2 wings, have push it close. When it close enough, and then it will completely go into here, and yeah, okay. Okay.
Sorry.
Yeah. So when it go all the way, this finger will go into here, go into the gap and push the coupler out.
Okay.
Yeah. So it's very well designed. It's also.
That makes sense.
Yeah.
Okay.
Yeah. Now you try it.
That's a clever design. Very clever.
Yeah. Something. Yes. Now in the U.S., most of the way they use coupler, so they make a lot of money. Okay. Then we here press the. Let me take it out. See here, there's what's that, a stand or something? Inside there's a hook. You press it down and you release it. Sometimes the problem is like we use a small. We open a smaller coupler and then we have to use another one.
Upsize it.
Yeah. Yeah, this is for the clamp, holding the clamp. Let's see, there's a there's a groove here, and then there's a groove on the clamp here, so they match, so they can hold you like that way. Capsular is easier, but you need to know how to do microsurgery, so you can handle the capsular better. Okay, that's the micro instrument. Now I want to talk about a little bit about the suture. So the suture at the beginning, I don't think I didn't feel there's too many things there until I have almost all the suture. I realized if you are the first surgeon in the microsurgery in the hospital, definitely you need to understand what is the suture, some knowledge about that, or you have to suffer a lot by using a wrong suture. But if you go to a well-established hospital, it's fine. The suture, they only pick the right one. Getting cold.
A little cold.
Oh my gosh.
Okay, now in a plastic surgery, hand surgery, you can write down. I will use AO, NIO. Yeah, write down. Yeah, okay. AO, NIO, 10O, 11O, and 12O. You don't have smaller than 12O. In Japan, there's 13O, but we don't have. So 12O is the smallest in the US.
12.
Yeah. So AO usually we use on a vessel larger than 3, like the DIEP. DIEP vessel is like the weight is about like 3 millimeter. So we use AO a lot. And then from 2 to 3 millimeter of the diameter, we use 9O. From 1 to 2 millimeter, we use 10O. Like the 9O, this one, 2 to 3 is about the radial artery or the ALT, kind of like that. And then the 10O, like this 1 to 2 millimeter, is like the common digital artery, or the proximal of the digital artery. And then 11O we use on some millimeter, less than 1 millimeter. Like it's close to the middle or distal frontal of the digital artery. When it goes to like half millimeter, like 0.5 millimeter, if you have 12O, it's better to use 12O. So this O,
12 for what?
12O for half millimeter.
Half
millimeter. This is AO. This is also an AO. So it's always about a suture. This is the 11O. This is the 10O. This is 10O.
Is there a suture there?
No, this is a package. I already used 9O. Okay, after a while, I realized the company they make suture is just like, okay, I have this kind of needle, and then I have this suture. Okay, I just make every product. But sometimes after a while, I know there's something wrong right there. Like AO, this is AO. AO is the suture size. So it's like 0.4 metric. So this metric is a pharmacology number. It's hard to relate to like centimeter or inch. So this is an instrument suture. This is 0.3 metric. 10O is too bright. Okay, move from this one to the side. And this is 10O. 10O is 0.2 metric. 11 is 0.1 metric, and the 12 is this 12 is the 0.01 metric, like 1/10 of this one. So suture is that, yeah, and then more important actually is the needle. Like this needle point AO, this BV is blood vessel, 130 micron. That's the
blood
time.
vessel.
Yeah, well, BV. And sometimes you will see PS is plastic surgery, and sometimes for skin. For skin, I remember Dr. Hoki tell Joyce, he asked a professor, somebody, what is PFS? Very sharp. Very sharp. Actually, it's for skin. It's kind of a cutting needle. Very sharp. So blood vessel, 100 micron. That's the diameter of the body of the needle. So the force is the category of the suture. So here's 5.1 millimeter is the length of the needle. So this figure is very close to the real needle size, like this tiny figure. 5.1 millimeter long, 3/8 circumference. So the needle for plastic surgery, microsurgery, we don't like the half circumference needle. And taper tip. Taper tip is considered as a traumatic needle, like the cutting needle for skin. You don't want to use cutting needle on the vessel. And then what happened there of this one is like this vessel, 130 micron, 3.8 millimeter. It's really short. Remember what size of the needle, what size of vessel we want to use on AO. AO we use on a
3.
big vessel. That's a big vessel. Is kind of
10 times the size of the.
Yeah. Think about it. This needle is very very short, and then we have to use it on a big vessel. That's totally wrong. So I get this suture from our cooperation lab. We transplant as bioengineer vessel to femoral artery on a monkey. That vessel is like about 3. And then they asked me, oh, what kind of suture do you like? I said, okay, AO. And then when I go to the OR and I have this AO, it's really hard to use. Sometimes
You couldn't even
pass it. And I have to do 2-step every stitch.
Right.
And then I realized, wow, not all the AO is the same. This is the AO I use in the lab.
Yeah, makes
So
sense.
I asked them to donate this one to the training and then buy the new AO. So I use this AO. This AO is better for the bigger vessel. So I go to here. This is a NIO. Take a look at this one. The same needle of this AO. The thing about the NIO suture, still on using a bigger needle. So actually I like this needle much better. 100 micron and 5.1 millimeter long. So I like this. I use this one very comfortable on a 2 to 3 millimeter vessel. And this one is even crazier. See the size of the shape of the needle? It's a spatula needle. What the hell? I mean, why they make a needle like that way? So I found this needle on ophthalmic suture. So they stitch on the eye. They use this kind of needle. And you know what? I asked my friend. He told me because the eye tissue is really tough. It's not like the vessel. We can pierce very easy. So the eye tissue is really tough, sticky. So this needle, the body is easier to hold it stable, and also they don't pierce the full thickness of the eye when you're doing the cornea replacement. They want to take half by, partial by, because once they take the full thickness by, the eye inside the eye there's liquid, so they don't want to leak out, and they also don't want the bacteria come into the eye through the needle hole. So this needle is easier to holding stable, and also easier to partial bind. So, but they name nice vascular, 100 micron, still not good. So this two is not very well. So this is better. And now take a look at this one, 10. Now this is the same needle of this. So it's way smaller. And the vessel, thing about a 10 we work on 1 to 2 millimeter. So this vessel is big, but they use the same needle. That totally didn't make sense. So they just make more product. Like this one is the 11 sub-millimeter, 3.8 millimeter long. The same needle.
You have,
Yes.
we have a blade.
Yeah, now
to
we
use
use on the sub-millimeter size of the vessel,
the
and then
same, the same.
same length on the 3 millimeter vessels. So you can imagine how I feel. I use that length of needle
Yeah.
working on a femoral artery. So like this, but this needle is half diameter, the 50 micron, so it's really small, taper tip. This is very close to the figure of that. Now this is a 12, so this is a 2 millimeter, so it is really small, very small, and 50 micron the diameter, 3/8 circumference, taper tip. Yeah, so now I want you to understand the needle and the suture, they make difference. They are not always the same. So when you go to a hospital or go back to your hospital, the nurse asks you, oh, Luis, what kind of suture you want? Just cannot just tell them AO. They may buy you 1 box of AO, like this AO, and then you have to use 5 years to use up to finish it, and then you may complete every day.
I will quit before that.
Yeah. So like this one, you can donate to our training. So this is from the transplant lab. The PI, the attendant bring it from the OR. So this suture, the vessel, the needle is 170 micron, 8 millimeter long, and you can see the suture is 60 centimeter.
Huge.
Yeah. Have you go to the transplant or cardiovascular surgery?
Yeah.
So they tie nuts by hand.
Yeah.
They hand tie nuts.
So you need it that long.
Yeah, so they did that long, and they also do running, so they did that long. And you know when they are tying nuts, the nurse will spray water on their gloves so they won't kind of sticky, so they hand tie
So it
nuts.
doesn't break.
Yeah, so this is super long. But most of the microsurgery in plastic surgery be like this is 13, and some of them is 15. 15 you will already starting to feel too hard, too long to hold it. You feel it will never end while you're pulling that 15 centimeter long suture under the microscope. It kind of double the feeling or even triple the feeling of that.
Yeah.
Okay, now move the microscope in. You can take a look at the needle. I cannot see where it is. This is a 9/0. You see this in the 9/0 suture. See that? So on here there's a needle, right?
Holy.
So you can compare the 9/0, that's a 5.1 mass of, and comparing to this 2 millimeter.
That's
Yeah, you can touch you can try to
That's
handle
insane.
it.
I thought the box was empty.
You can handle it a little, yeah, pick it out or something.
This is insane.
So tiny. Oh, whoa.
lost the other?
I don't know. Maybe.
We'll find it. Oh my god, I broke it. Oh, I lost it too. Weifeng,
Huh?
we're losing your sutures.
Wait, is this mine?
That's the 9 though. Let's go find the.
Wait, okay. Maybe
Got
there's
it?
one over here.
Holy.
That one seems big though.
Oh, that's huge, huh? Weifeng, we lost 2 12-0s. Here it is.
Yeah. I try to bring it to this side.
Oh, there's another one.
Can't see.
Yeah.
Oh my god.
It's over here.
Yeah.
It's right here.
12 is hard. Okay, yeah. So that take our 9-0. 9-0 is easier. Now you can try. Yeah, pick up a 9-0. You know, the robotic surgery company. One day they called me, they emailed me, said, asked me a question. You know the question is, do you know what's the weight of the 9-0, 10-0, 11-0, and 12? They want the weight of the suture.
Oh my god.
And I said, why you ask that? They said they're working on the FDA approval, and then the FDA said, you are the robotic instrument, robotic system handling the tiny suture, so give me the data. What is the weight of that needle and suture?
Did you weigh it? It's
Yeah.
impossible to weigh. How do you weigh that?
Yeah, so the company have no idea because there's the data is really in detail everything, but
Right.
it's just missing the weight.
Right.
So they don't have no idea how to get a weight. And then at the beginning I thought they asked the wrong question. Nobody care what is the weight of the suture. Probably there's no weight there, it's very lightweight. But they said we have to answer that question. And then there's a chemical scale, you know the chemical scale.
Right.
And then I try. And then I tried I put the AO, it come out some number, like 0.006. And then I put maybe the 9 is going to 0.003. So I just put it on there for 3 times and I write down everything, what I got. And then actually when I put the 11-0 on there, didn't show anything, even like 0.000 or something. And neither 11-0 and 12 didn't show anything. I just tell them 0. Yeah, but they get their data and then FDA approved. So they just leave their data. It's crazy. Actually, it didn't make any sense.
That's nuts.
Okay, now today we try a little bit on the suture. So, like the way to catch a suture, pick up a needle is, I take one needle out. There's a needle.
That's right.
Yeah. So, I pick up the needle. So we want to pick up the needle most of the time, like perpendicular to our needle holder, like that. So this is the most stable way. But sometimes we want the needle, most of the time we want the needle parallel to the vessel in the real practice. This way we can pick up, you can stitch the vessel and line up the entry bar and the exit bar easier. Yeah, now you try a little bit, pick up the needle, put it in the right direction, and then stitch on here, and then tie a knot. Yeah, I cannot see it very clear just by guess.
That's insane. You're doing that without a microscope.
Yeah, so mostly tie 3 knot is enough for the microsurgery. Okay, now you try a little bit, and then
How did you see that?
yeah, and then next time you can go. Yeah, so the dilator, you can use a dilator, and then use a. I didn't turn on the ring of the phone, so the ENT fellow he come in, but he didn't know I'm here, so he go to my desk, but then didn't see me there, and then he put a scale there. I want to talk with him, discuss how to make that mandibular reconstruction microsurgery model.
I can cut for you.
Oh yeah. You wanna try?
Oh, sure.
Wow, a lot of money on it. Yeah.
Oh my god. What?
Yeah.
This spray is a lot of money. Yeah, so the patient is laying like that, maybe just can turn the head a little bit, and then when they do, they need to connect the fibular artery to the facial artery. So they said the position is really not comfortable. So we may 3D print a scale, and then make a defect of the mandibular, and then put our chicken thigh in there,
That's nice.
and then practice anesthesis in that right location, simulating to the real facial vessel artery, and
Super
then
nice, yeah.
and so they can practice in that very bad position.
How do you do the 3D model?
It's easy. There's 3D print file online, or you just download it, and then maybe remove part of that, and then we just print in here. Yeah, the idea already there. Just need to talk with the ENT fellow, so or even Dr. Cho, they also understand what is the situation. And after we make that model, we just ask them to do an osmosis on that, and then fill out the survey, and that's a paper. That's a quick paper. Yeah, did you tie enough?
Yeah.
Mm-hmm.
Yeah, there's a couple here.
So tiny.
Yeah, here's one more suture. Okay. Yeah. Try this suture also.
That's correct.
Were you in your, like, did you finish?
I did finish.
Which program of your general president?
Which program I was at?
Uh,
I was in the University of Puerto Rico. Yeah.
what's the craziest case you see?
Craziest?
Yeah.
I guess it's just a little different, but maybe ED thoracotomies are a little bit crazy, you know, kind of like have to open your chest in the middle of the ED. Just different crazy than plastic surgery, I guess.
Yeah.
Did you know you wanted to do plastic surgery when you?
No, I wanted to be a cardiothoracic surgeon.
What helped you decide on plastics?
A couple of things, but I did enjoy doing a couple of different procedures. I like the creativity of plastic surgery and kind of like being able to be on the a little bit hopeful side of medicine, and you know, kind of like after cancer, after recon, and then there's not much plastic surgery in Puerto Rico in terms of reconstruction, so there's a lot of need for, oh my god, the suture got cut with my jeweler.
Yeah, right here. Okay, that's it today. First day, first lesson. So we talk about basic things. So now you go to the OR, at least you have the basic foundation, understand what happened. Yeah. Yeah.
Thank you.
Let's talk
my friend.
about,
This is amazing.
Talk to the camera.
Hey.
That out.
That's amazing, honestly. Great teacher. Thank you for everything.
Yeah, so hello everyone. Welcome to our channel. So today we have our PGY 5 resident. Four resident, Luis, and our research fellow at M3 between M3 and M4 medical student in our university, Myiah. So today's introduction for them to prepare them to go on a trip to South America, Dominica, right?
Dominican Republic.
Yeah, Dominican Republic. Yeah, we will host a micro course there. There may be 20 or 40 residents. There will be a Western Olympics doing microsurgery. It will be very fun. So I want to help them to have the skill so they can go there to set up the course and also teach in the course. And we go through the microscope and instrument and suture and tying some knots for the day, and it's fun, and it's about 2 hours. We didn't feel that's 2 hours long, so we enjoyed it.
It was fun.
Yeah. Okay, so Luis, tell us a little bit like now in your mind, which one is helpful for you today? Something helpful for you.
From today?
Yeah, today.
Everything. Just being able to recognize and choose the proper instrument and sutures to do your surgery. I think it's as important as being able to do it. So.
Great. Yeah, Myiah. Yeah. What things you feel like in your mind helpful today? Something new?
Yeah, I think it'll be really helpful when we're in the Dominican Republic, when we're doing the blue blood chicken thighs, having the right instruments and having techniques to make the catheter insertion as easy as possible.
Yeah.
So,
yeah, great. Yeah. At the beginning practice how to make the chicken thigh model. It's a really simple and easy model. It's great tool, learning tool for the microsurgery treating. Yeah, it's also cost effective. Maybe when we use, since we use chicken thigh, we never go back to use a rat because they can train practice on the chicken thigh so well.